Thank you for the opportunity to speak today. I've been tasked with covering vaccine boosting, when, with what, and does previous infection matter? And it's a very, very big area, so I have by no means covered all the literature in this area. What I've tried to do is to cover some of the main themes, and I hope that that'll give you a sense of the complexity of boosting. So at the moment, we're in crisis mode, I would say. We are focused on building immunity as quickly as we can by the rapid deployment of vaccines. And that's shown here on this schematic that I found on an article in The Conversation by Kylie Quinn, which shows you what we're trying to do at the moment. So either using a one-dose schedule, the Johnson & Johnson, or more commonly a two-dose schedule, we're administering vaccines to get as much immunity as we can, as quickly as we can. But that is variable in how successful we are being. Vaccines have been developed at an unprecedented pace, but the coverage is incredibly variable, and I thought I would show you this slide to make that point. So on the left-hand side is the whole world, and on the right-hand side is Africa. Grey shows you people who are partially vaccinated, and black people who are fully vaccinated. And you can see that it's a very, very different situation when you compare Africa to the rest of the world. South Africa, where I live, is shown on the right-hand side in the red dot. And you can see that thus far we have actually only managed to vaccinate less than 1% of our population. And the reason I make this point is that I think we need much more creative and efficient ways to use vaccines well, and often that comes down to boosting. What we are beginning to understand, I think, is durability, and what we mean by that is how long protection will last. And of course, that is integral to boosting. Boosting will happen when the protection that we've triggered by vaccines, whatever that might be, wanes to a point where you are no longer protected. And ideally, that's the point at which we want to boost you by a second vaccination. From efficacy data, we're getting reassuring signs that, that the efficacy will continue after vaccination to last for quite some time. This is the efficacy data for the two RNA vaccines, Moderna and Pfizer. And you can see that out to about 120 days, you're getting pretty good maintenance of vaccine activity. So the split between the placebo and the vaccine arm stays much the same or increases, which is good news in terms of durability. The same is true for the adenovirus vectored vaccines. So that's the AstraZeneca vaccine and the Johnson & Johnson vaccines. And you can see that while the efficacy is slightly lower, you can see that it continues out quite far now. So this is good news. It suggests that the vaccines that we have generally deployed do trigger probably antibodies and other immune functions that last sufficiently far out from vaccination to protect you way past 3 or 4 months. What we know much less about is correlates of protection. So correlative protection is essentially trying to define what it is in the immune system that is protecting you from reinfection or infection after vaccination. And the reason you need to know what the correlative protection is because that defines the threshold at which you are no longer protected. And that would be a key thing to understand for boosting. There are more and more modeling studies that come out, and I'm showing you one down here at the bottom right, that suggests that neutralizing antibodies may be a key correlative protection. The higher these are, the better the efficacy of various vaccines, as is shown here. But I think there's also a substantial body of data, although I focus largely on antibodies in this talk, a substantial body of data to suggest that T cells and Fc effector function may well be contributing to protection, though perhaps in different situations. So there are a number of questions regarding boosting, and I'm going to try and catch as many of them as I can in 15 minutes. The first of these is, does the timing of the boost matter? So vaccine developers tend to provide a very regimented regime that goes out, and people generally have been sticking to that in the rollout of vaccines across the world. But there is some data to suggest that the timing of the second vaccination, the booster, might be something we can tweak for good. This is data from the Pfizer vaccine that shows extending the interval between the first and second Pfizer dose actually produces better antibody responses in older people. And that's not particularly surprising from an immunological point of view. There's good precedent for this in immunology. But let me show you how this is done. So at the top here, the timeline shows you that the first vaccine was given in both cases. At the top line, the second vaccine, the booster, was given at 3 weeks, whereas down at the bottom here, the booster was given 11 weeks after the first vaccination. So quite a substantial difference. What they've done here is to compare immunogenicity 2 weeks after the boost. So it's at this time point for the top line and this time point for the bottom line. But you can see that after the booster vaccine, there is significantly better binding antibodies in people who had a longer duration between the first and the second. And in fact, there's also some data from the AstraZeneca vaccine trials that also seems to suggest that in people who received booster vaccine more than 6 weeks after their first vaccine, perhaps showed better efficacy than those who received their booster in less than 6 weeks. And I think this is particularly interesting. If there's no detriment in spreading the doses apart, this would allow greater population coverage. But it's a bit of a trade-off because in many cases, people who have not received the booster vaccine have low immunity. So you may get better coverage of a population, but they'll be less well protected. So it is a bit tricky. Does everybody respond to initial vaccines and booster vaccines equivalently? This comes down to a number of vaccines that might be needed. One of the major questions we've been interested in South Africa is whether immune responses are efficiently elicited by vaccination in people living with HIV. Of course, the reason that we are interested in that in South Africa is because our country is home to 7.5 million South Africans who are HIV positive and more than 2 million who are not virally suppressed. So we have an adult HIV prevalence of 19%. If it turned out to be that that vaccines were less efficient in HIV positive people, that would be a significant problem for many countries like mine, where HIV is a common issue. Fortunately, the data that we have so far for AstraZeneca in this case seems to indicate that HIV positive people who are on ARVs and immunologically stable, an important point, seem to mount equivalent responses to vaccination. So this is AstraZeneca, looking at binding responses on the left-hand side to full spike and on the right-hand side to the receptor binding domain at day 0, day 28, and day 42. And you can see that when you compare HIV negatives to people living with HIV, in this case, no significant difference, and that's reassuring. But little is known for other vaccines, and I make the point again that even less is known for people living with HIV who are viremic and not on antiretrovirals, people who are immunologically compromised. And there's good reason to suspect that these people may be at increased risk of not responding to COVID-19 vaccines. Immunogenicity has been shown to be reduced or absent in several immunosuppressed patients, such as those who have hematologic malignancies, people who are on immunosuppressive therapies such as rituximab, and people who've had transplants and are on immunosuppressive medication. In these people who react in many cases at very low levels to vaccination, we may need to consider prioritization of these groups for a third dose in 2-dose vaccines, and it perhaps even push those immune responses out with a 4th or a 5th dose. There is some data to suggest this will work in a case study of people who do fall into this category. Those who showed very low responses to initial vaccination have boosted antibody responses after a 3rd dose. The other thing that I think we need to think about when we talk about boosting is that perhaps we need to think more broadly about boosting and consider the use of monoclonal antibodies, which are passively administered, so do not rely on people's immune systems and might be invaluable here. Although, as with vaccines, these would come with accessibility issues. Of course, the other question that's becoming more and more common as more and more vaccines are deployed is, can we mix and match vaccines? In other words, can we start with one vaccine and then have a boost with a second vaccine that is outside of the traditional regimen that various vaccine manufacturers have received. And Angela Merkel certainly seems to be a proponent of this approach. It was, I see it in the BBC News a couple of days ago that she received the Moderna booster after the AstraZeneca prime. And more, this is what's happening. The question is, does it work? And I think it looks pretty promising to me. So that approach, mix and match, would be referred to as a heterologous prime boost. And there is some data, and I'm showing you one example here, that mixing the two vaccines may result in very good immunogenicity. Here, the comparison was in people who received a prime and boost of the Pfizer vaccine compared to those who received a prime of the AstraZeneca vaccine and then a boost of the Pfizer vaccine. And if you compare the immunogenicity up here, you can see that there's no significant difference between the two groups, and that prime boost really triggered very good immune responses. Again, this might be very valuable in countries where access to the RNA vaccines is more limited. The AstraZeneca and Johnson & Johnson vectored vaccines are much cheaper, much more stable. So the idea of priming a population with those kinds of vaccines and then bringing in the harder to access, more expensive RNA vaccines would be another good way to get high level coverage in countries who struggle to access vaccines. And regardless of what we tell people to do, I think in real life, this is going to be increasingly common. People are going to mix and match. Of course, probably the biggest question is how often and when will we need variant-derived vaccines? This phylogenetic tree shows you some of the craziness that can happen when you look at the evolution of SARS-CoV-2. And we're all very familiar with the fact that we are now dealing with increasing numbers of variants that emerge and show some resistance to vaccines. The answer to this question, I think, is we don't know yet. But what we do know is that the higher the potency of antibodies that we're able to trigger by vaccination, the better the preservation of activity against variants. So that is shown here in one of many, many publications across the world from many, many groups that make this point. Here, the comparison is looking on the left-hand side at Pfizer and the right-hand side at AstraZeneca. This is down here is Victoria and B.1.351, which is now known as beta, and it's one of the most antibody-resistant variants circulating. And you can see that in Pfizer, where you start with a nice high geometric mean titer of over 1,000, against the variant, you still have quite reasonable activity, a GMT of 150. But when you start with a low mean neutralization, geometric mean neutralization of 300, the activity of those antibodies against the variant is very low at 34. You can see that the slope of the curves is actually very similar. So the loss of activity against the variants is generally very similar regardless of which vaccine you look at. So the key thing here is that potency is queen. The better the antibodies you have to begin with, the more chance you have of neutralizing variants. One way in which we can harness this is by using the fact that many people have previously been infected with SARS-CoV-2. And so I'm going to show you now the effect of prior infection on vaccine responses, which is pretty dramatic. There's several studies now that have looked at this. This is a study from Michelle Nussensarg's group that compares convalescent donors who did receive no vaccine. You can see on their in the black lines here, there's kind of waning of neutralization. But here in the blue, you can see what happens when people who were previously infected have waned to some extent, and then here receive a vaccination. You can see that their antibody titers shoot up to very high levels. And perhaps what's more important is the panel down here at the bottom, which shows that those infection/vaccination triggered antibodies are very good at dealing with multiple variants, again, pointing to the fact that the more potent your antibodies, the better they are at dealing with variants. This is another example from Leo Stamatatis and Andy Maguire, again showing the effect of prior infection on vaccine responses. In this case, the gray dots here denote Pfizer, responses with in the absence, I better get this right, in the absence of prior infection. So these are standard vaccines, 2 vaccines, no prior infection. And whereas these dots up here, these much higher responses, are antibody responses seen after 2 vaccines, but after prior infection. You can see very high titers up in 1 in 10,000, equivalent to what you would get in very sick people who've been hospitalized. More importantly, I think, these antibodies are able to neutralize both Wuhan 1 on the left-hand side, but also beta, the variant detected first in South Africa. So again, high responses that are able to neutralize multiple variants. I think the other thing to point out in this slide is that the second Pfizer dose here was not particularly useful. As you can see, here's this first dose, second dose. And you can see that, that it didn't really add much. So in this context, the second Pfizer dose was essentially wasted. Again, something to think about in countries where we don't have very many vaccines. This is a similar study that we've recently done, looking at people with no previous infection, and those either infected with in the first wave in South Africa with the original variant, or with beta in the second wave. This is the Johnson & Johnson vaccine, so a vaccine that differs from those that previously shown you. And again, you get nice responses in people who are vaccinated, but in those who were infected first and then vaccinated, you get whopping great big titers, much, much higher. This is binding antibodies, but the same is true for neutralizing antibodies and FC effector function. So really dramatic effects. And I think all of this is being pulled together very nicely in this article, which argues that there should be access to SARS-CoV-2 vaccines, of course, for everybody, but that we could very effectively use a single dose for COVID-19 survivors and achieve much better population level immunity. And it's true, this would result in much greater coverage, but it comes with huge logistic difficulties, particularly in low and middle income countries where you would require point of care testing for antibodies to assess if people have previously been infected. And that adds a layer of difficulty to vaccine programs that are already sometimes struggling. So vaccines have been developed and deployed at record speed using very well-tested intervals and doses. However, immunogenicity is lower in some groups, requiring new approaches in boosting, perhaps third, fourth, fifth boosts, but also thinking about monoclonal antibodies as a heterologous boost, if you like. Mix and match strategies are inevitable. People are going to start doing this, are already doing this, and they're immunologically interesting and sound. There's good reason to think that this might work. We need to do more trials to understand what the good combinations are and what the less helpful combinations are. But this approach may well alleviate periodic shortages. If we can find ways to efficiently harness prior infection, then that may enable faster coverage and generate higher titers. And those high titer responses are really likely to be the best solution to variants. Thank you.